When it comes to how mental health symptoms present, how patients are treated, and how they receive care, gender plays a critical role. It can influence diagnosis, treatment planning, and patient provider communication. Our goal for this next hour is to provide you with strategies to recognize common biases, avoid diagnostic blind spots, and deliver more inclusive care to people of all genders. And to help us with that, we are joined now by Dr. Roberto Olivardia. Dr. Olivardia is a clinical associate in psychology at McLean Hospital and maintains a private practice where he specializes in the treatment of ADHD, body dysmorphic disorder, and OCD, as well as issues that face students with learning disabilities. He is a nationally recognized expert in eating disorders and body image problems in boys and men. Roberto, always such a pleasure to chat with you. Thanks for joining us today.
Great to be here, Jeff.
Well, let me start by asking you this. With the benefit of hindsight, and you've garnered a lot of that over the years, what would you most like to convey today to newer providers looking to better understand the role of gender in mental health care?
Yeah, it's a great question. I mean, I think in a nutshell is, sort of going on even in the last talk that Doctors Crawford and Coyne were talking about in terms of leaning in with humility, curiosity, and for clinicians to recognize the biases that we may have as a gendered person ourselves and with patients, that we're working with, and to really look at this with curiosity, as we'll talk about over the next hour, how this it interplays with everything from diagnostics to assessment to treatment to what patients bring in, but also to have people sort of look at within themselves what we bring in as clinicians in terms of our notions of gender, our own experiences with our own gender identity, and biases that we may have around treatment and research and all of that.
Roberto, when it comes to gender considerations in mental health care, it seems that there are two distinct categories: issues around traditional gender roles and issues for individuals with a non binary or gender non conforming identity. Can you explain the distinction?
Sure. So when we're talking about traditional gender roles, we're talking about the kind of more societal and cultural kind of expectations of what men and women are in terms of, everything from their expression to certain expectations, responsibilities, roles that are these culturally defined roles. And with non-binary or gender non-conforming, these, are individuals that don't feel like they exclusively fit into one or either of those categories, and as far as gender nonconforming, may express themselves whether it's in the form of dress or other sort of forms of expression that don't again neatly fit into these categories of what we call masculine and feminine.
We'll be talking about both of those categories, if you will, as we go through the conversation today. How might traditional societal expectations of masculinity or femininity influence how a clinician approaches their treatment process?
Yeah, I mean, I think in a lot of ways, Jeff, I mean, one of the things that's important is to even think about what those terms mean. Like, what do we even mean when we're talking about masculinity or femininity? I remember, growing up and, reading, I don't even know for what it was, but, like a masculine individual is assertive, is confident, is strong, a feminine individual, and it was obviously masculine was typically associated with men, feminine with women, nurturing, warm, loving. I'm like, okay, like I didn't always, I mean, I had parents who both of them embodied all of those characteristics. And so I'm like, okay, so if you are warm and nurturing and you are a man, does that make you feminine, or are you just a man that's warm and nurturing? If you are assertive and strong and confident and share your opinion and you're a woman, does that make you a masculine woman or just a woman who is assertive? So even when we think about those terms, it's important to think about like how have we defined them? And as clinicians, we're all coming from different generational viewpoints about this and different family upbringings and our own cultural sort of definitions and modeling of this. So there's a lot even to unpack when we even approach what these terms even mean and to be aware of the language that we use even to our patients around, this these masculine traits you might have or feminine traits. When we use those terms, what we mean by them and what are we conveying, sometimes even inadvertently in a way that could actually be shaming or invalidating to patients. But it's there. I mean, it's definitely. I mean, as far as diagnoses go, as we'll unpack. I mean, there's gendered notions of many diagnoses that a lot of times we're not really trained or talked to, or it's talked about even in our graduate school or medical education.
So, broadly speaking, do you find that cultural norms around gender impact one's willingness to discuss their emotions in mental health?
Oh, absolutely. I mean, and also just to always preface when having these kinds of conversations that we're not saying that all men or male patients that I've worked with fit into this category and all female patients fit into this category. So as we're talking about this, we're talking about kind of whole group differences. So if we were to do a study on 1,000, male therapy patients and 1,000 female therapy patients, and 1,000 non-binary patients, that you will find certain differences, but obviously there are a lot of individual differences. So, on speaking on a more global level, definitely that. I mean, I would say that generally with male patients that I've worked with, often have sometimes there's a sort of hurdle of even being in therapy, and sometimes the discussions I have with them at the beginning are around how do you feel even being here? Like before we're even unpacking why they're there, whether it's for depression or OCD. But I have had many discussions with male patients around what it feels like to even be in therapy, where with a lot of female patients, non-binary patients, I've had those conversations, but not as frequently because for men, it's often shaming just to even acknowledge that there's a problem that they need to work with. The other thing that's important to understand too is even when they're not necessarily, they themselves may not feel that way. So I've had male patients who are like, I'm glad to be here and I want to work on this. That the average male, I would say, patient that I've worked with has not had the same kind of practice in a sense of talking about their emotions than the average female patient that I've worked with. Now, the good news is I've seen that shift a little bit with younger um, boys and men that I work with, where I think I'm hoping that'll change. I mean, we're in a very strange place in our country now where there's, this backlash, I think, around that. But um, so sometimes even the emotional kind of literacy, the vocabulary, how to articulate emotion sometimes can be more difficult, for men than what I would typically see with women. And also, but with women to understand too that they're coming, into a space that I find a lot of times with women as opposed to men, that the discussion may not be so much that they feel ashamed about having a problem, but particularly with mothers that I work with, there's a lot of sort of shame around, oh, do I deserve this time to be going to therapy for an hour? It takes a half hour to get there when I could be doing something for my family, for my kids, for this, for that. So we have to be aware as clinicians of even to validate. Yeah, it's like the old adage of like you have to put the oxygen mask on yourself, before
Sure.
your kid, and being aware that women are socialized to put themselves last in many ways, especially women who are within families. And it's not just moms. I mean, I remember, years ago working with a woman who she was one of five children and she was the only daughter in this Italian American family. And anytime there was a health issue with either of the parents, it was her responsibility, despite the fact that she had four brothers who all lived just as close to the parents as she did. But it was her responsibility to take them to the doctors, to tend to them, to do all that because she was the girl, she was the daughter in the family. And so being aware of what expectations culturally that intersects with gender, but she had a lot of guilt about coming to therapy. She knew she had issues with anxiety and other issues she was working with, so she didn't have shame around that, but she had shame around, I could be doing something for someone else. And that's sort of, so it's almost like it's not that one men, women, non-binary, that one is worse than the other. It's just these unique kind of issues that we always have to be aware of that people are coming in with.
You have raised so many important issues that I want to circle back to and talk about more in depth. But let me ask you one broad question first and kind of tap into your experience for some expertise here. Over the years that you've been doing your work, what can you tell us about the evolution of gender considerations in the mental health field overall? Do you see the trend line moving in the right direction for the field?
I do, yes. I mean, I think, what's important historically to understand is that, when Sigmund Freud was talking about patients and developing theories, and a lot of the history is really based upon sort of, upper class individuals, of, that often did not include people of color, that either were around boys and men in certain models, and then in other models were just focused on women in certain ways. So that even like research on certain diagnoses that we're really kind of it's not as historically grounded, that you were doing research, let's say, I mean, as you mentioned, one of my areas of specialty is in eating disorders and body image in boys and men. And I could tell you when I started doing that work 30 years ago, they were very, I mean, like almost non-existent sort of studies looking at boys and men. And now we know from more research that's been done that it's 1 in 4 people who have an eating disorder is male. And that would have been almost like unheard of to think about, years ago. I also specialize in ADHD, and it's still a misperception that boys outnumber or males outnumber females in having ADHD. That's true in terms of identification. Women and girls are vastly underdiagnosed because of the conceptions of how we think about ADHD. Even when we look at depression and anxiety, and we could unpack all of that, that there are these sort of gendered notions. There's definitely been a shift. I think part of it too is even in training as clinicians. I mean, my training was very psychodynamically informed and oriented, which I appreciated. And all of my training at McLean, a lot of it was more CBT focused, which I appreciate. So I feel very fortunate that I had a lot of training in different models. But the one thing about the more traditional psychoanalytic, psychodynamic model was one of that, this sort of boundary, and it wasn't as relational. And I remember even in grad school, this having a discussion about self-disclosure, and it really was more the notion of like, no, like as a therapist, you don't do that, which it just didn't feel. I'm a very relational person, Jeff. Like it just didn't seem right to. I it felt like to me, I'm a non-person in the room, and it's not about me. It's not like, oh, I need to say this. It's about, does that serve our clients and our patients well if they feel like they're talking to a wall, like in some ways, and if somebody, and it's not that, there are some patients that just they don't know anything, and then there are other patients that know certain, like that I'm a music lover, and that I have ADHD, and like in certain things like that. And I credit the feminists, when feminism came in, and clinicians in the field, and going to Dr. Judy Jordan and people like that who are talking about feminist, more relational models of, no, you can be in a relationship in the room without compromising the professional boundaries. And that really, was something that was looked at almost like through a feminist lens, whereas the more kind of masculine lens was one of like, no, there has to be this like, which is kind of interesting, isn't it? Like the parallel process of that. Like if we're trying to, work with these notions, and yet the therapeutic model in and of itself can be very gendered in many ways.
Oh, so many questions coming up. Let me start with this in terms of diagnostics. Do you find that standardized diagnostics tools can play a role in either perpetuating or mitigating gender bias?
Definitely. And I can tell you, I've had personal experience with this with my work in eating disorders and boys and men. I remember one of the first studies I did. I was in college at Tufts University. My mentor was Dr. Harrison Pope, who's a psychiatrist at McLean. Mentor, amazing, amazing mentor, and he supervised this research. And there's a very popular eating disorder survey called the Eating Disorder Inventory, the EDI. Very valid, reliable instrument. Clearly I'm going to use it. And these were male college students in this first study that I did from colleges around Massachusetts. And this young man had said, "Oh, I have a question on what," he goes, "What are thighs?" And one of the questions was like, I am satisfied with my thighs. And you had to rate, agree, disagree, all of that. And I, pointed to the part of the body. He's like, "Oh, you mean like the quads, like that area?" He's like, "Oh, I've never heard." And, he's college educated person. He's like, "Oh, I never heard the word thighs before." Then there were other questions that like popped up that were, definitely more like female centric. And I'm not saying, I understand that because historically, when we think about eating disorders, we think about it as affecting women. So obviously, a lot of these questionnaires and surveys are going to be normed with female population. But our responsibility in the community is to make sure we're continuing to research and tap in and realize when things are evolving, that research instruments and assessments have to catch up to that. And that I can say has happened a bit, within the field of eating disorders, but there were many studies that actually had found that when men with eating disorders would fill out certain surveys, they would not screen as having an eating disorder in certain surveys, which means they were being missed because of how certain questions or items were being assessed. And so it's a challenge, making sure for us that we're looking sort of at all of those. I find even with something like depression. Now here we have, you know, depression, this sort of term that of all the different psychiatric diagnoses is, I mean, most people have heard of it and whatnot. I remember even in grad school and learning, okay, that women outnumber men, tremendously. But let's look at again what that means. Like maybe these sort of traditional notions of what depression is, but we also know that men who are depressed might express that in a very different way. That there, I've worked with many men who are depressed who, when screened for depression, don't really relate to sort of some of those things. But at the same time, might like to give you an example, even the idea of feeling worthless, that's sort of one of the criteria of depression and feeling worthless. And I remember a male patient years ago saying, "Well, I never really relate to that, but I don't." And it's not that he said that he feels good about himself, but the idea again of when a male even can say to themselves, "Oh, I feel worthless," is could already be violating in some ways some masculine construct and inherently be shaming. So you feel bad that you're depressed, and then you feel bad that you feel bad because you're depressed. And so that like sense of worthlessness, and yet this was an individual who did not feel that he had much to contribute to the world. He did feel ineffective, but he's like that term just didn't really resonate, with me. Um, or with I work with men who are depressed who, the notion of like getting not being able to get out of bed or being slowed down or whatnot. Some of the men I work with who are depressed are, if anything, they're kind of running around in like in a chaotic very impulsive ways. So they might be in the world and they're getting out of bed, but they're almost like escaping and running away from, their feelings in a way that doesn't look traditionally depressed. We know that the suicide rate is much higher in males than it is in females. So clearly there are a lot of men that are not being captured even in sort of this depression diagnosis. So it is a call to action to let's look at and make sure that all surveys and questionnaires and instruments are being normed in, within all populations. And that includes, whether we're talking about gender, people of color, because we also know there's a lot of biases and assessment measures that tap into certain minority groups as well.
Roberto, in terms of culture, I'm sorry, in terms of gender biases, you've touched on a couple of conditions that came to mind for you, eating disorders, depression, for example. Are there other conditions that tend to be more at risk of over or underdiagnosis based on gender norms?
Yes, so I would say, I would say depression, definitely. That I find that, interestingly, a lot of men who I work with who might have like a diagnosis of intermittent explosive disorder, who might have a diagnosis of antisocial personality disorder, that these are men who could also be depressed. And sometimes that is the thing that's happening, but it's sort of coming out in this more externalized way. And again, traditionally, that is what we typically would see with depressed men is more externalizing behaviors. They act out in ways, sometimes aggressively towards other people, which obviously doesn't make them sympathetic characters for a lot of people. It's hard to sort of see a man who might be very belligerent and threatening, and not that we should excuse that behavior, of course, but to see, oh, this could be somebody who's very vulnerable and feels very fragile and feels very depressed. Similarly, with women, there could be a lot of women who are diagnosed with depression who in some ways might actually be, could be angry and could have sort of a lot of other feelings that come out, but that it just comes out in sort of this depressed sort of manner. Because for women who are socialized often to not be angry, to not even be assertive, let alone to, be angry, who sometimes when I've worked with women and they're describing situations, I'm like, no, that's totally appropriate for you to be angry about that and frustrated about that, and sometimes feeling like they don't have that space, so they tend to internalize those emotions. So even with something like depression, anxiety, I mean, also gendered, I would say that's sort of often gendered in a way where you typically see with like women as being like worriers. And sometimes with men to say that they're feeling anxious, that they're worrying too much about something, feels again this sort of like attack on their manhood. As I mentioned, eating disorders, ADHD, vastly underdiagnosed in women. Now, why is that? Is because we know that girls with ADHD traditionally tend to internalize their symptoms. Again, this starts young, Jeff. Like, so the boy with ADHD, as I have ADHD, that um, you could be rambunctious and I could be the class clown. I could find it was very easy to identify the other boys who had ADHD. I could find my peer group very quickly and connect within that peer group. Well, we know that girls, for example, who are more hyperactive or impulsive tend to be ostracized by their female peers. So they tend to be more accepted by the boys, which then imagine that experience that now some girls are like, great, fine. My peer group just happens to be all boys. But then the perceptions of that for that little girl, sometimes from other girls or boys, could not always be so favorable. So there can be a very different experience, but we also know that a lot of girls with ADHD tend to internalize their symptoms by being perfectionistic. So you can have a girl that's getting straight A's in school, but she is struggling, or she comes home and is melting down. Whereas the boys with ADHD were like, whatever, if I don't get the homework done, I don't get it done, and it's that like, that energy. So we see that. I would say with borderline personality disorder, definitely a gender diagnosis where you typically see and associate with women. And there are many men that I've worked with who might get an antisocial personality or narcissistic personality, where they might also have some of those traits, or could be misdiagnosed sometimes as having bipolar or bipolar spectrum disorder, and actually a borderline personality disorder. And even with the men I've treated, that some of them really have a hard time with that, like this idea, because they're aware enough about the diagnosis and thinking like, isn't that teenage girls who are self-harming? And I'm like, no, there is a spectrum. And I'm not an athlete or sports person, Jeff, but there is a male athlete, I believe he's a baseball player, who came out and revealed that he was diagnosed with borderline personality disorder. And I'm always so appreciative as a clinician when celebrities and people who have a certain platform talk about mental health issues and destigmatizing it, but just also show just a different representation, a different face of what it could look like, in the same way that when, I think his name was Mike Margema, who was a baseball player who talked about having and struggling with an eating disorder. And it's so important to have that kind of representation. But I've worked with many men who have BPD, borderline personality disorder. Autism spectrum is another one that we typically would see with males. Now, the studies do show that more boys are affected by ASD than girls. However, the disparity is not as big as I think the research studies would show. It's that what we also know is that girls with ASD tend to be more socially isolated and more just introverted, and sometimes are sort of labeled as like just being introverted, and in some ways too, people might not sort of feel as put off, I think, sometimes by that kind of introverted behavior in girls, whereas with boys with ASD who might present, let's say, in more socially awkward ways or more introverted or sort of picked up, in a different way. Um, so we see it in a lot of different places. I mean, I think, it's almost like one of those things, the more we sort of look into it, like, I mean, OCD, obsessive compulsive disorder, that I remember working with a woman who, I mean, it was clear to me her symptoms, what she was describing, were sort of very ruminative, kind of obsessive, intrusive thoughts that she was having, but she had been diagnosed as having generalized anxiety disorder, the sort of worry disorder. And I'm like, no, this is more than GAD. I mean, you're talking about these things that are, very kind of what would be called like pure O, or pure obsessional kind of thinking, although they were actually eventually coupled with like certain mental rituals. And I'm like, no, that's OCD. But it was almost, and I'm not casting blame, on a clinician or whatnot, but I think it's hard again to not, or it's hard to separate that we do have our biases as clinicians. I mean, myself included, around certain things that might have us think, okay, this is someone who's just like worrying a lot. So I think it would be interesting, whatever diagnostic group that clinicians out there tend to focus on or work with, is dive into it and almost like think about the ways that gender might intersect with how we look, how we diagnose it, how we identify it.
I definitely want to circle back to that last point. It's such an important one. I want to ask you, Roberto, about intersectionality, the whole concept of layered identities. When it
Mm.
comes to gender, how does that impact both diagnostics and treatment?
Yes, and that's so key, Jeff, because obviously, no one exists in a vacuum with just one identity. That, we're coming in as clinicians with these varied intersectional identities. Our patients and clients are coming in with that, and that sometimes is part of the intake for me. Is, I was very fortunate. I got my PhD at the University of Massachusetts in Boston, which, especially at that time, was very ahead of its time in terms of cultural competence, and really looking at these, that back then they didn't call it intersectionality and intersectional identities, but that's pretty much how I was educated in that program, which I'm very grateful for. And understanding that, part of the intake process is when I'm asking somebody about their family and family dynamics and family culture, is trying to understand what their role in the family and that culture is. So that woman I had mentioned before, coming from an Italian American family, she goes, like, eh, I my own bias was like, why are you the only one like taking care of, your parents? Like, you have four brothers, and again, I'm not apologetic for having that sort of, reaction. I mean, I didn't say it like that to her, but it became clear that that was almost less of the issue for her. She's like, that's just how it is in our family culture. Like, that's just how it is. That was not what she wasn't coming into therapy saying, I want to know how to assert myself with my brothers and have them do X, Y, and Z. She was talking about some of this other stuff. And so it is important sometimes to balance like the parts of us as clinician that obviously we want our patients to live healthy, optimal lives, but we also have to be aware of making sure we're also respecting and validating, cultural identities, in that are sometimes going to be intertwined, with those gender roles. Now, I think therapy is being a safe space to challenge some of those things and to lean into it and to be curious about it. And at the end of the day, the patient is going to find their way as to how, what their gender role and cultural roles and, their age, all of that, how it sort of like comes together, in that kind of way. And so I'm always fascinated by that in terms of, how people, how all of these kind of intersectional identities come in. And there has been change. I mean, I definitely have seen, um, in a good way, again, like with boys that I work with who are more open than what I would have seen 20 years ago. And there are a lot of criticisms I can talk about with social media, but one of the things that I would say is a good thing is I do think for certain pockets that it has destigmatized a lot of things where people may hear other people talk about, certain things in the same way that girls who, could feel like there's more permission to talk about things and assert themselves. So that's sort of intersectional identities of understanding like generational identity. Like when I'm working with someone with ADHD, for example, being aware that even though I have ADHD, I did not grow up with iPhones. And I mean, my parents didn't get cable, Jeff, till the day I went to college
Wow.
because they knew who
You're
their son
old,
was.
Roberto, and so
Well,
am
no,
I.
they did that purposely. I begged for MTV, trust me. And and my parents were like, we're saving money for college, but they also knew I would have been glued to I love media. I could consume it, and so they took that temptation away. I was the last kid on the block to get an Atari. So it was in some ways my ADHD symptoms were somewhat managed in some sense by not having access to those things. Whereas now, I'm a parent of a 20 and an 18-year-old, and who both have ADHD, and I was very aware of, okay, they're growing up in this culture where, so how do I control that? And of course, they got iPhones later on, I would say, than their peers. But at the same time, when I'm working with a college student, to know when they're talking about getting distracted, it's, I mean, there's such a different validity to that than it would have been 20 years ago. So there's a generational identity too that intersects with all of that.
We've been talking a lot about traditional gender roles and stereotypes, for example. I want to shift the focus for just a moment or two here and talk about gender diverse individuals. And perhaps you can define that term as it's used today for us first.
Yeah, it's a large umbrella of basically, if we think about in a sense all that we know of or think about with masculinity, femininity, man, woman, girl, boy. And we think of gender diversity as what is outside of that dichotomy, um, in terms of, again, gender expression or gender identity. And these are things that are not easy to wrap your head around. And I can tell you, is it just, again, a personal example is like, I could understand, I mean, certainly like gay, lesbian, bisexuality. I could understand a trans sort of identity, somebody who, was assigned male at birth, who is, female. I get that. Non-binary was a term, Jeff. It was so hard for me to understand that and wrap my head around. And of course, I want to, like, I want to affirm who my patients are, but it was not an easy concept to understand. And again, to go back to what Doctors Crawford and Coyne was saying about the humility and curiosity is, as clinicians, when we don't always understand that, one is to put that out there. Because when I had, a client who said they were non-binary, I, said right off the bat, like, this is not an area I have expertise in. I can't say I fully understand it in a way. So, um, if there's a specialist that they wanted to work with, because I wanted to make sure that they were getting, and they wanted to continue working with me. So part of it was they were going to let me know who they were, and I was going to lean into that. And it's my responsibility. And I did get continuing education around it, took some courses from experts within that field to really have an understanding of that. Because I grew up in a culture where there was that term was not used. Like we had in the 80s, they used to call people like a tomboy or things like that. And to know, and that, not to say that non-binary is that, is like, I just didn't know what it was. Like, it was a very hard thing for me to. And so as clinicians, when we don't understand that gender diversity and things like that, we get training on it. Like if we refer someone, or both, to someone who definitely has expertise in that. So they're individuals who, yeah, don't fit and don't identify with these terms of male, female, man, woman, don't identify with the expressions of the sort of typical kind of expression. And there are biases that clinicians sometimes have around it. And as clinicians, we, I would say as a whole, are probably people that are less judgmental than the general population. I mean, hopefully, are more affirming. That doesn't mean we're free of, any biases. And I've, had conversations with various clinicians who, say, oh my gosh, like, and sort of roll their eyes when, they have a patient that is gender non-conforming and wondering, like, are they doing that for attention, are they, and those kinds of things that we have to be aware when those thoughts come about, because this is the experience of gender diverse individuals. Is it's a very, very difficult navigation to go through the world when you don't feel that you fit into that dichotomy. Because I mean, I remember even in the 80s and 90s, for someone who identified as bisexual, that was very difficult. That was not inherently embraced by the gay community or the heterosexual community. That there was a sort of sense of like, oh, you're not making up your mind in some ways, as
Mhm.
opposed to people. But what I think that spoke to, Jeff, was people's discomfort with someone not fitting into a category. Like, what? Okay, like what's wrong with the concept of somebody who could be attracted to people of the both, sexes? But there is this, I do think there's almost this like human nature in some ways to want things to fit into a box. I think of like the high school experience, like every high school movie that's based in high school has like the jocks and the nerds and the punks and the goths and all of that. And of course we go to college and we realize, oh, this is like not how the world works. Like this is just something that we need to put in boxes. And at the same time, there is an element of how the world works that wants to kind of put, whether you're a woman, you belong in this box, you're a man, you belong in this box. And so I think that gender diverse individuals really challenge that for people, including clinicians, to be like, recognize that part of us that might want things to be neat and like simplified in that kind of way.
Let's bring all this back to the clinic and patient centered care specifically. Do you find that there are common disparities in care for transgender, non binary, and gender expansive people?
100%, absolutely. I mean, well, one is, the access to care. And I obviously we have to mention, I mean, we're living at a time in 2025 politically where there's an active um sort of mission to basically, kind of erase these identities, to almost, to completely not acknowledge, to completely invalidate individuals who live, with these lived experiences. So this isn't just ignoring something. It's not ignoring it. There's full attention on this population to basically prevent them from getting gender affirming care, whether that's medical care, whether that's psychiatric care, whether that's hotlines, Jeff, to for people in who are struggling with suicidal ideation. I mean, really, like we're in a place where we're gonna not have a hotline for people who want to end their lives. I mean, to give them that kind of support. And we know that this population is at significantly higher risk for attempting suicide than within the general population. So one is just even access to care. I live in Massachusetts, McLean Hospital. I feel very fortunate to live in Massachusetts. We live in a very affirming state. It's only when I travel around the country for conferences and talks that, I mean, I know it, but I don't, like when you hear people's experiences when I go around, I'm like, oh my gosh, like there isn't a clinician like 40 in a 40-mile radius that can do that kind of work, with them. Now, thankfully, with telehealth, that has helped and expand. But there are people, I get emails from people sometimes that are looking, within even in their state. So there's that. Then there's, the financial implications of that, but it's also finding therapists who are specialized in this work. So, we have to, and I this is happening to catch up with sort of training clinicians and therapists starting in undergrad, graduate school, medical school, and continuing ed, how to work with these populations. Because there are a lot of clinicians, and I was one of them, that like, I want to help, I want to affirm, I want to elevate people, but I didn't, at one point, didn't have the tools, Jeff. I'm like, I don't know, and I don't want to. I know my heart is always in it, but I don't want to inadvertently say something or do something that's going to be harmful, in some ways. So I had to seek that training, and that even wasn't easy. Like for me to find like the right kind of experts in continuing ed and training course. So it's finding clinicians, it's having the sort of access to care, and it's recognizing that these are individuals that even when there is access to care, there's a tremendous amount of fear around walking through a door that might be an identified clinic, let's say, for gender affirming care, because there's a tremendous amount of violence against this population. And I know this sounds so bleak in ways. It doesn't mean there isn't help out there. There's definitely help, and there are communities to tap into. But as clinicians, we have to be aware of all of that. So sometimes when you have a patient walk through your door, that may be, years into that, journey for them that has to be unpacked, in the same way that I would say, like, I mean, I'm not comparing the experiences, but years ago, I don't see this as much now, thankfully, but years ago, the typical male I saw with an eating disorder had struggled with it for a long time before he sought help. And that was in the research that we find that men seek help a lot later into, things. So it would be, and we have to understand that gender diverse individuals, a lot of them by the time, especially older gender diverse individuals, who didn't have the community that younger people have, didn't have the visibility, the media representation, have struggled for years and are not always trusting of clinical and medical environments. And we have to hold that as clinicians and validate that to be like, I understand why you might not trust me or trust this sort of frame because it has been used against people, in many, many ways.
Roberto, let me ask you to speak directly to somebody newer in the field. Let's say that they want to set up a safe and affirming space for gender diverse clients. What can they do at a very practical level to make that happen?
Yeah, I mean, sometimes, a little can go a long way. Asking what pronouns they use, asking them, if there's anything that could sort of make the space more available. If you are a clinic or an office and you have, pamphlets and brochures, in your office, um, having representation of various kinds of identities that just show people that there isn't this sort of like one, frame, in that. Also just being open about what you don't know. And it's not about the client having to educate the therapist, although I have many, especially my younger clients that I work with, they love educating me. Like they feel like they're sort of, they're the expert, and they are in their experience. And at the same time, I tell patients, I don't want you to feel the burden or responsibility of having to educate me. I'm going to seek that out. But obviously, you have to educate me on you, on your experience. But you don't, I don't ever want someone to feel like they're speaking on behalf of all trans individuals or all non-binary, individuals. In the same way that years ago it could be like for a person of color that you're representing like every Hispanic person or every, like, that's just not fair to them. So but to be open about that, to be open about what you don't know and what you will seek out, because that also communicates a sense of respect. And I know I was working with someone at that time and I told them I'm seeking this continuing ed course. I actually showed them the brochure of the course I was taking and asked them, does this look like something that you, as someone with this lived experience, would want clinicians to know? And he, this individual who I used to identify as he, identifies as they, said felt very touched by that, that there was this sort of respect around understanding that, and being aware too of like that, sometimes with pronouns, the wrong pronoun might come out. And how do we talk about that, in the therapy space, in the safe space of, how a clinician might feel around that, the impact it has, on the person, and understanding that these are things that could happen outside the therapy space. So yeah, a lot of times with patients I've worked with, it's things like that, it's the kind of what can seem simple, like on forms that you have people fill out, typically formed male, female, check up, have a category for, non-binary, trans, for other kind of identities. It makes a huge difference, just the inclusion of that.
Do you find that most of your patients have the vocabulary to express what they're feeling when it comes to gender? And if not, how do you work with them to make sure that they're fully understood?
Yeah, not, I would say, interestingly, Jeff, that's where this generational intersectional identity comes in. I would say with younger people that a lot of them are, I would say, pretty good and articulate at sort of expressing that and feeling less apologetic for their identity and defining kind of who they are. With older gender diverse individuals, yes, that there's and I again, there's a years where there was no language to talk about, that or representation, that it can be very difficult. And that's part of the work, is how do we navigate that. And for some patients, it doesn't even, something that feels like it has to be labeled as something might not even need a label. It's just, this is like who I am, this experience. And it doesn't have to have a particular label. It's, I am this, and these are the different parts of, my identity. Because sometimes also there's almost this, I have heard with younger people who sometimes feel a pressure because there are a lot of different labels of gender diverse, which I think overall could be affirming. And then I've heard from some young people that they feel almost this pressure of having to decide which of these labels that they fit into. And that's when I'm like, don't feel a rush to do that. Like, the more important part is you determining, like, who am I? And we, it's like we figure out who we are first, and then we pick something that we can identify with, as opposed to, oh, I have to look at these boxes and kind of conform even to a gender diverse label. If that makes sense, like, so it's almost like, let's first figure out like where you are, and not feel like we even have to say it's this, or that, in that way. Because I think sometimes, and I get this, because especially with younger folks, there's such a need for community. We all have a need for community, but particularly with this population where it's sparse, the community out there. And in some parts of the country, there is no community. And so I get the almost the fervent nature of trying to rush a process of, like, to be like, okay, I fit into this, so that there's this like kind of support and community around that.
You, as a clinician, often work in teams, I imagine, working with
Mhm.
clients. How do you approach a situation when a colleague might have a different take on gender issues than you do yourself?
Yeah, that's come up in different ways. Some, I would say, with the more traditional sort of male female, where whether it's in some of the things I mentioned before, borderline personality, ADHD, that I, I in those kinds of cases sort of assert sort of how, I see it, and being aware that even if there are different perspectives of it, that at the end of the day, that we want to make sure that, the treatment model is one that's going to help the patient. But that's going to happen because, again, as clinicians, we're coming in with our own intersectional identities, with our own biases. And I I enjoy working within teams. I value the input that, everybody has. And I recognize that there could be biases that I bring in, to certain things as well. I'm not immune, to that. But I would say when those instances have come up, for me, it always warrants a conversation with that clinician around just understanding where they're coming from, having them understand where I'm coming from, really with the goal of, we both have the same goal of helping this individual have a more optimal level of functioning. Let's just make sure, though, that you know, we're on the right track, and how are we sort of, seeing that. Um, and sometimes, I mean, what's been great, sometimes I've had those conversations and people have been very receptive, to sort of my input, on it. Um, and looking at it in that kind of way. I think I have not personally encountered this, but I've heard this with other clinicians when it comes to gender diversity, that there can definitely be more around that, where gender diverse individuals also tend to be pathologized by the nature of being gender diverse. Like this assumption that if you're non-binary, that that's like, you know, you're not really non-binary, you probably have, depression or autism spectrum or something else, like as opposed to no, you could be non-binary and have autism spectrum and, be depressed. Um, and that in that one of the trainings I did, the clinicians of those trainings had talked about many examples where that happens, where just the notion of being gender nonconforming in and of itself was seen as the pathology, as opposed to even looking at what else was going on. And that was very frustrating, for these clinicians.
What is your take on where the field is in terms of training for newer folks in the profession? Do you think that these gender issues, both the traditional norms and gender diversity, are being addressed adequately in training programs?
I think it's getting better. I wouldn't say adequately. And I only say that because patients are not feeling like they're always fully heard in therapeutic spaces and medical spaces. So in that sense, I wouldn't say adequately. I think we can always do better. I do think there's definitely a shift and a movement, and this is where, with more visibility, with more people talking about their lived experiences, that it, it would behoove us not to, as psychiatrists, psychologists, social workers, to lean into again with curiosity and try to understand this, because we're going to have patients come into our space looking for help who have these identities. So I have seen an increase. I think we have a ways to go though. Definitely.
Question came in from a viewer. Let me read this to you. Do you have any advice on how those of us living in a less affirming location might be able to signal that we are a safe space coming from a social worker here without possibly putting ourselves or our patients in harm's way?
That's a great question. Yes, I think, sometimes it's even in speaking in generalities around, this is, a space regardless of, your background or, identity. And it can be just one of many things, because sometimes, I think making it can, I think, scare some patients sometimes if they feel like this is even going to be written in their record, or whatnot. And sometimes those are discussions too, that in certain spaces of what gets included, in records and notes and things like that, what diagnoses get used, and knowing again, and there is validity to this, that, like gender, dysphoria diagnosis, and like who gets to see that, who has access to that, where does that get sort of shown, if you're in a medical setting and you're not getting gender affirming care and that diagnosis is there, are there going to be certain biases? So I think just even in speaking in generalities of being an accepting individual, and also being, I think again, it also as a clinician to convey, like there are a lot of things I might not know or understand, but I am the kind of and I have said this to my patients, like I am the kind of person that I'm always seeking to understand where people are coming from. And I'm disclosing about, like, my family background was one in which, my dad would say no one is superior nor inferior to you. We all have a role and a place, and our goal is to sort of just understand where people are coming from and connect with people. And my family culture was one in like, just you elevate the person next to you. You just it's as simple as that. And I disclose that as a way of also letting people know, like, even if there's something you're struggling with that you think could be bizarre, or could be like, oh, this guy is not going to understand this, or you're in a part of the country where people aren't really trained, but a clinician is sort of put out there that their like ethos is one of which, I may not get it, but I'm still going to have your back. And that's what I want my patients to always feel, Jeff, that I have their back, like regard. And if I don't understand it, I will help them find someone who does, or I'm going to find the information and educate myself on that. And that goes again a long way, because the reality is we're not always going to understand it, but our patients need to know that we're the kind of people that when we don't understand something, unlike what we see happening in this country, we're not going to, attack an individual, verbally or even in relationally, that when we don't understand that we can tolerate not understanding something and not demonize an individual because we don't understand it. And that is happening far too often to a lot of people.
Roberto, as we start to wind things down, I want to ask you to kind of zero in on some key takeaways. We've covered a lot of ground, and this might be even a little overwhelming for somebody newer to the profession. What do you want them most to take away from your conversation with me today about the role of gender in patient-centered care?
I would say the most important is I would love people to almost just reflect on, maybe it could be, five patients that they've worked with recently, or maybe it could be a couple diagnostic groups, OCD, eating disorders, schizophrenia, what they work with, and just kind of almost as a mindfulness, as like what ways does gender intersect, interact, show itself, in this. Have people also reflect on their own, gender identity, what it means to be like. I'm very aware that in when I was training at McLean and working with women with eating disorders, being very aware of the dynamic of gender, that I am a male specializing in eating disorders, working with women. And many of these women would talk about their negative body image and talking about, what they felt men wanted them to look like. And here I am, a male in the room. And I wanted them to feel safe for that, that I won't be offended, because I'm not assuming they're lumping me in that category necessarily. And even if they were, like, their experience is their experience. So being aware of like, like how does my presence, and if you are a clinic, there are some clinicians like, how do we express our gender? Because, I think my patients who know me very well know, like, I'm a very sensitive person, like a very, very nurturing person. And at the same time, I grew up in Somerville, Mass. And I would say the culture of Somerville when I grew up was kind of like tough in a good way. Like you kind of say it like it is and that. So and again, I grew up with, like, when I think about my mom in particular, who was incredibly warm and loving and was fierce at the same time. Like I don't know. To me, there wasn't this sense of like, oh, women are this way, men are this way. It's like I just grew up with this notion of these are the traits that I'm gravitating to, and looking at things like emotions as not being a liability. And part of it is my family upbringing, and part of it is my love of music, because music is all emotional. So there's no way any part of me was going to denounce being an emotional person, because then that means you're not a good musician or songwriter. That would never happen in my universe. But being aware of like who we are, how we're expressing ourselves, and being authentic in the room, and recognizing that that might come up, sometimes. Like I have had, you know, um, well, it could happen with men, or women who have said, oh, I'm not, like, I feel bad, like I'm not, a traditional woman. I don't like to wear makeup, and I don't like to paint my nails, and I don't like to. I'm like, well, that, and they still identify as a woman. I'm like, well, yeah, that you're a woman that just doesn't wear makeup. And but I have to understand that, you know, their socialization with, especially with other girls growing up, was like that there was a real sense like that they were looked at as bizarre, let's say, for that. Whereas for me, is I'm like, well, so what? Like you weren't wearing makeup. What's the big? I mean, I would, again, I'm not saying that like that to them, but being aware of like, oh, wait a minute, my experience, like I, I don't wear makeup. That's not part of like sort of my socialization, in that kind of way. So yeah, so for people to almost like look at this with reflection, and then what would be even better, talk to a colleague of yours, like a good friend, colleague of yours, and talk to each other about, especially if they might have a different, if it's a different gender identity than you, that's even better, of like how each of you sort of see certain things, because that's really what this whole day, I mean, this whole training is really about, is to inspire conversation and going back to curiosity around it.
What a great place to leave things. This hour has flown by, and you have given us a lot to think about regarding the role of gender in mental health care. Roberto, thank you so much for carving out time for this conversation today.
My pleasure, Jeff. Always a pleasure.
Likewise, Dr. Roberto Olivardia.